Hello and welcome to our Champion Series Module 4, Implementing PPE Auditing. This presentation is provided by the Thunder Bay District Health Unit's IPAC Hub. A portion of this presentation was originally presented by Public Health Ontario and has been adapted by the Thunder Bay District Health Unit's IPAC Hub for educational purposes only. The content and graphics are original to Public Health Ontario creators Lori Schatzler and Michelle Ramirez. The following slides will provide you with a refresher on best practices for personal protective equipment use. You are probably using more PPE now than ever before, so we will just quickly review the proper guidelines surrounding this. We will then be discussing the importance of auditing as a tool for practice improvements in healthcare settings. Auditing is an important strategy to support long-term improvement in your practices, so it should be integrated as a regular part of your infection prevention and control program. Of course, we acknowledge that you are busy, so you can consider what you have capacity to implement into your IPAC program at this time. There are several key steps to implement auditing in your organization. Step 1 is to plan. Step 2 is to audit. Step 3 is to evaluate. Step 4 is to implement the strategies. And step 5 is to improve and sustain. This presentation will provide considerations to take during steps 1 through 3. Steps 4 through 5 will be implemented in your workplace during day-to-day tasks as an IPAC champion.
We will now review the first 3 steps, starting with step 1, plan. There is one essential step that everyone must take before we choose our PPE. This step is the personal risk assessment or the point of care risk assessment. In healthcare, the personal risk assessment is the first step in the care process and is completed before every interaction with a patient or resident to determine if the situation poses a risk to you or others of being exposed to an infectious agent. This assessment considers your patient, the task you are performing, and the type of interaction you will have to identify appropriate precautions that you must take for the care activity. We have included some resources here. So the first one is for recommendations for use of PPE for care of individuals with suspect or confirmed COVID-19. It discusses different types of risk assessments where strategies to protect healthcare workers can be implemented. To safely provide care, you want to make sure you have practiced properly putting on and taking off PPE. There is no shame in reviewing this process as many times and as often as you need to. Everyone should be aware of the limitations of PPE as well as how to care for it, especially if reusable PPE is being used. Now that you've reviewed the best practices for PPE and what PPE users need to know, we are going to discuss one way we can promote compliance and improvement with PPE best practicing. That is PPE auditing. Public Health Ontario has just published 3 documents to help implement or improve PPE auditing in your setting. There are 2 observation tools. One is supporting the use of PPE in healthcare settings, and the second is auditing of PPE use. A document to help guide the use of these observation tools to audit and improve PPE practice at your setting is the At a Glance document. It talks about implementing personal protective equipment audits in all healthcare settings. Over the next 3 slides, we are going to discuss who should be involved in your PPE auditing. Your organization should identify at least one person to oversee implementation and the maintenance of the PPE auditing program. This person should have the support of the leadership within the organization. They should also be well respected and able to access high-level administrative resources within the organization. Ideally, they would have appropriate clinical experience or broader experience in quality and safety. It is important to engage decision makers and influential healthcare workers early on in the planning process. This is to maintain their engagement during implementation and beyond. A working group or committee can be established to champion your PPE auditing program within your organization. This group can consist of a coordinator or person responsible who works with the management team to identify individuals or resources within the hospital to be trained as in house trainers and observers. It could also consist of a trainer, someone who should be influential within your organization and who would have basic knowledge of infection prevention and control, as well as patient and resident safety. This person could also be an observer. The observer should be a healthcare worker with experience donning, doffing, using, and working with PPE. Both observers and trainers should attend practical training sessions to learn when and how to audit PPE. This basic training session should include the importance of preventing healthcare associated infection and how transmission occurs. They should have a good understanding of the proper technique for donning, doffing, and using PPE, and other considerations such as the proper disposal of PPE. Auditing programs are important to help achieve long term improvement in healthcare practices. Improving adherence to infection control practices requires a multifaceted approach that incorporates ongoing education and continuous assessment of both the individual and the work environment. There are both immediate and long term benefits of auditing. Long term benefits include facility wide improvements in IPAC practices that can be achieved by consistent auditing and feedback of results over time. Auditing should also not end at the observation and reporting of results. The gaps identified during audits can be used to help inform improvement programs as we try to understand why these gaps are occurring to begin with. These improvement programs may involve education, skills practice, or culture change. Immediate benefits can also occur through timely feedback of observations directly to healthcare workers. This can help staff identify gaps in their own practice that they may not recognize and also promotes accountability for their own behaviors. Auditing should be conducted in a way that allows a snapshot of practices across all staff types, shifts, and time of year, as this will provide a more accurate representation of practices and will allow you to compare the data and focus resources where they are most essential. Ongoing auditing at regular intervals is best to ensure that the benefits are achieved and maintained over time, and to capture issues or gaps as early as possible. A culture of safety is critical for auditing to be effective and well received by your staff members. Without this culture of safety, staff members are unlikely to accept the auditing process, they may feel they are being disciplined, and may reject your feedback. This culture of safety and transparency can allow us to provide and receive feedback in an open and collaborative manner. There are a few key points that should be kept in mind as your facility works towards developing this culture of safety. It should be acknowledged that there are many barriers beyond the individual that can affect compliance, such as time, workload, and PPE supply location or availability. We should all encourage a judgment and blame free environment where staff are able to observe for areas of improvement and share errors or near misses without fear of punishment. We want to avoid staff feeling as if it is a disciplinary activity or for them to feel uncomfortable with receiving the feedback. We should also encourage collaboration across disciplines to ensure there is a spokesperson from each discipline to provide input into the auditing initiative and also to advocate for the program to their colleagues. As you can imagine, this is not a one-day process. If you don't already have this open, transparent, judgment free culture, it will take time and persistence, but you can start by being role models and educators on the benefits of it. And you can help identify other staff members that are highly respected by their colleagues to role model this culture as well.
Now we will move on to the next of the 3 steps. Step 2, audit. For this step, we are going to review how and what should we be auditing, and we will also go through the process of auditing and show you Public Health Ontario's PPE auditing resources and tool. So as mentioned previously, Public Health Ontario has 2 audit tools, including one for supporting the use of personal protective equipment in healthcare settings, and one for auditing of personal protective equipment use. The first type of audit is conducted on a regular but occasional basis to identify compliance with those factors that help support the use of PPE best practices in healthcare settings, including observations on policies and procedures, training, and supplies. For example, you may conduct this audit on a monthly basis if there are frequent concerns, or on an annual basis if there are no noted issues. The second type of audit is identifying compliance with the actual use of PPE by staff in the clinical settings. This is the actual observation of staff handling their PPE and donning and doffing prior to engaging with a patient or resident or client. The first audit type is used to assess items that support the use of PPE and identifies 3 factors that should be audited on a consistent but occasional basis. The first factor is administrative. This would include existence of current policy and procedures on PPE, for example, if they're reviewed annually, including training and procurement. It would include PPE requirements, such as training and testing being communicated to possible contractors and documented. Staff and contractors have current fit test results for N95 respirators, and audit results are communicated to staff and used to develop monthly education refreshers and messaging. Training factors include all new staff have received training at orientation, including a practical review. All temporary or agency staff are oriented to PPE and IPAC practices and resources, and are also assigned a more experienced staff for first few shifts. All staff receive annual refresher training and when deficiencies are observed. All visitors and caregivers receive training. And IPAC leads or shift change leads provide PPE reminders and audit results at regular huddles. Lastly, supplies factors include alcohol-based hand rub is available where donning and doffing PPE. PPE is available and easily accessible in different sizes, but also stored safely. Disinfectant wipes are available to clean and disinfect reusable eye protection. Waste and laundry bins are available and are not overfilled. Isolation carts or PPE carts are not used to store patient supplies. And responsibility for restocking and cleaning carts and emptying waste or laundry bins is identified. Now let's look at our second audit tool, the auditing of PPE use, which includes 3 parts: general information, observed staff member, and compliance. General information will include data that will allow you to analyze and break it down to create more specific comparisons. This includes the location, the date and time, and the type of precautions. Information like this will allow you to provide PPE compliance results specific to a unit or location, the type of precautions, and the type of shift, such as day versus night shift. The next factor, indicating the staff member being observed, will allow you to compare or identify where strengths or concerns are within different staff groups. Third and last, The compliance section looks at sequence and technique. This section includes the room setup, including appropriate placement of precaution signage, accessibility of PPE supplies at point of use, and distinction between clean and dirty. It also includes observations on the appropriate sequence for donning and doffing of PPE and other safe practices, including doffing location, disposal of PPE, appropriate disinfection of PPE, and safe removal techniques. And finally, there is a section on the bottom for scoring the audit. Now let's look at observation numbers. When determining how many observations to make to produce meaningful results, it is important to keep a few considerations. It is important to have a large enough sample size to be meaningful. Not collecting enough data means the rates are not reliable, as any changes could be due to chance alone rather than the effect of the intervention. For 100 beds, it is estimated that 56 observation sessions of 20 minutes each is needed to collect enough data for reliable compliance rates. This provides for approximately 200 observed opportunities. The time frame for the audit should be no less than a 2-week period in order to capture a large enough number of random observations. Auditing information that is collected can be provided as immediate feedback or planned feedback. When providing feedback, it's important to include specific details, as this will help to be able to recall specific gaps or strengths that you observed. The staff being observed should also be allowed to provide feedback. Appropriate timing of the feedback must be considered. The feedback collected can be used for comparison or long-term trends. And most importantly, you should always aim to keep the feedback non-threatening by providing it in a safe atmosphere and in a manner where the staff member does not feel they are being judged or punished. Immediate feedback is often considered the most effective form of feedback. This is given right after the interaction when behavior is fresh in the individual's mind. It can include the observers, managers, supervisors, or peers, and it can be provided on the spot. The staff or healthcare working being observed should also be allowed to provide feedback, as they may actually be able to identify barriers that can help with the development of future improvement programs. Planned feedback is given at predetermined intervals, for example, end of the year audit results or performance feedback. It is usually more setting-wide versus individual results, and is typically the responsibility of a designated department or assigned role, such as the manager or IPAC lead.
Okay, and now we're going to do a concept check. With all the information we have reviewed, we feel it would be best to apply it in a scenario situation that we can work through together. So our following scenario is the following. You are an employee in an adult assisted living group home and you are completing PPE observations for the day. One of your clients is ill with respiratory symptoms and a nasopharyngeal test is pending. Signage has been placed on the door for droplet contact precautions. Your care coordinator is going into the room to provide continence care. You watch them don their PPE in the following order. They perform satisfactory hand hygiene, put on their mask, then eye protection, then their gown, and lastly their gloves. Is this the correct order? Take a minute to think and recall what we have reviewed so far. If you need any additional time, feel free to pause now. We will go through the answers and the reasonings over the next few slides. Okay, so hand hygiene always needs to be performed prior to touching clean PPE. So this was correct. What we didn't do is we did not stipulate if there was any source protection ongoing within the home, as we've been kind of like doing lots through the pandemic. So we're going to assume that it's a regular measures. But we have included if the staff member was already wearing a mask under universal masking, or if the staff member was already wearing their mask and eye protection, so universal facial protection. So we're going to give a check mark because hand hygiene is first, and then we're doing that before touching clean PPE. Next, what we see them do with donning is something common due to COVID protocols. Individuals are already used to wearing masks, and they may feel like this is the most important thing to do. So they technically will gravitate to putting on the mask first. However, when we aren't already wearing any PPE, we're going to remember to work from our body. So start at our body and work our way up. So the correct answer here would actually be following hand hygiene. You would want to put your gown on next. So if we're working from our body, we've already done the gown. So next, as we come up our body, we would hit our mouth. So this is when you'd place your mask on. So doing the hand hygiene, mask, and eye protection is the incorrect order. What we want to see is under regular, hand hygiene, gown, and then mask. And then due to universal masking and universal facial protection, they would already have this on, so you would just skip that step. As we continue to work up further our body, we're now passing our mouth and we hit our eyes. So we're going to continue and we're going to put our eye protection on. If you have universal masking on, you don't have your eye protection on, so you'd place it on then. And with universal facial, you already have that one on. Finally, you are done putting on all your clean PPE. So there's one last thing to cover, and that would be your hands. So recall, we started our body, we moved up our body till we got to the end, and now our hands are left. So we would cover those by putting our gloves on. So here is the PHO Public Health Ontario lanyard card for putting on your PPE when you're already not using any. So these are the steps under that regular title that we just saw. If you are wearing anything already, you just skip it and go to the next step. So now for the next scenario, we're going to talk about them taking off their PPE. So they have finished their care and now they're standing in the threshold of the room and begin removing their PPE. They remove their gown, then gloves, then they perform hand hygiene. Then they remove their eye protection and lastly their mask. Now, is this the correct order? Now, if this is when you're needing an extra minute, go ahead and pause. If not, we will continue on and discuss. Okay, so on the left-hand side here, we have their order for doffing their PPE. And on the right-hand side is where we're going to place the correct order. So they took off their gowns first. However, what you really want to do is to remove your gloves first, as they're most heavily soiled. Those are the items you're touching everything with, so they're going to be the most grossly soiled, so you want to get those off first. So after your gloves, you want to remove your gown. You can see here they just had the order of the gowns and gloves mixed up. However, there's always a exception to a rule. Some individuals are able to remove the gown and gloves at the same time in one fluid motion. So if they can adequately achieve this, and this is some can happen with individuals who don and off consistently throughout their work shift every day, and you're not going to see this with individuals who aren't as familiar with it. And it also depends on the type of gowns that you're using as well, if they can do this. So if you feel they can do this adequately, then it should be allowed. However, the correct order otherwise is always going to be gloves, then gown. So during the removal of your gloves and gown, your hands will become contaminated. So it's very important to perform hand hygiene after removing this PPE, especially before you're moving up to your face, because there are so many portals of entry on your face, your eyes, your nose, your mouth that you want to protect. So next we're going to look at removing our eye protection, as typically this has to be removed first due to the fit in order to remove your mask. Your eye protection will fit over top of your mask. So there are 2 check marks in a row there. So then once your eye protection is removed, you are then able to remove your mask. safely so we can see they have that order correct as well. And then finally, we want to perform hand hygiene at the end, as again, your hands became contaminated after removing that facial protection. So here's Public Health Ontario's lanyard card for removing PPE. So remember the donning one was blue, so the doffing one is green. You can see again just that correct order: gloves, gown, hand hygiene, then your eyes, mask, and then hand hygiene. And here I just want to put the two side by side. And I did want to note that this is not the reverse order of each other, right? So putting on and taking off, there is not the reverse, and we do have 6 steps versus 5 steps. Many people will think it'd be logical for most things we do with directions to do it in the reverse order, but what you have to really think of when you're doffing is what is most likely soiled or contaminated. Now, if you don't have any of these lanyard cards, you can contact us and let us know. We can likely supply you with some if you'd like.
Now we have reached step 3, evaluate. Now we will discuss a little bit about the evaluation of the auditing data, including how to calculate compliance rates and how it can be used to make practice improvements. Compliance rates refer to the percentage of observations where the correct practice was being observed. This can be calculated for a particular type of healthcare worker or staff member, for example, care workers and housekeeping staff. A particular category of practice will also be observed, for example, proper technique for mask removal or hand hygiene. In the example here, you would divide the total number of times that proper removal technique for masks was observed for a particular healthcare worker that you are currently auditing by the total number of observations of that practice for that staff category. This would include both observations where it was done properly and observations where it was done improperly. Then you would multiply by 100 to get a percentage of compliance. So if 26 physicians were observed removing their masks using the proper technique out of a total of 37 observations of mask removal, the compliance rate would be 70%. There are several different options for you to visually display and present your auditing data. How you choose to present your audit data may depend on exactly what information you want to emphasize or disclose to your particular audience. A good way to visually present auditing data over time is by using a graph or table format such as those shown in the slide. So you can see that the auditing data is being presented over a period of January to June in both formats. You may even develop an infographic that can help present the most important data in a concise, visually appealing manner. Depending on your organization, you may wish to email the data or present it in person. It can be posted within your facility, or it can be presented during leadership meetings, staff huddles, health and safety committee meetings, or IPAC meetings. Consider who needs to see this data and how to best get it to them. Be sure to not overwhelm your audience with too much data, cluttered or chaotic designs, or information that's irrelevant to them. There are many different benefits to having an auditing program, some of which we already spoke to a bit. You can share immediate feedback with staff to promote compliance with best practices going forward. You can identify practice gaps that may require an intervention to improve compliance, and also get in-person feedback from staff members on why these gaps may be occurring. You can assess the impact of interventions that have been put into place to improve compliance by looking at auditing data before and after the intervention was implemented. You can also monitor compliance with best practices over time and identify early if they are declining. Identifying these changes early on can ensure that timely action is taken place to address it. Finally, sharing auditing data can help promote a culture of health and safety in your workplace by getting everyone involved and promoting a collaborative partnership between IPAC, leadership, and frontline staff members. Once you have analyzed the data, you may become aware of gaps or barriers that are occurring. The next steps will be to identify actions to help correct the issues or to address barriers. This slide provides an example of an action plan to help organize the gaps and those barriers and how they may be addressed, who is responsible for the actions, and a timeline for completion. Keep in mind that different barriers require different strategies and theories. For example, are they communication, opportunity, or motivation barriers? And then to potential strategies for improving these barriers. Keep in mind that change is hard for those who have done things a certain way for so long. The world has changed a lot in the last few years and will constantly be changing as new information comes out. Congregate setting or healthcare workers must be adaptable to new ideas and practices that arise through scientific research and discoveries and implementation of new best practices along the way. We at the TBDHU IPAC Hub are always available for extra support and resources while you are navigating this new territory. And that brings us to the end of Module 4. Thank you for your participation.